Good afternoon, everyone. We are a little bit before 1, so we're going to give everyone a chance to join and get settled, and then we'll start in a few minutes. Thanks for joining, everyone. We are right at 1, so we'll give everybody a few more minutes to log in and get started shortly. We'll just give it another minute or so. Thanks for joining, everyone. All right, I am going to get started. It's a couple minutes after that hour. Welcome, everyone. Happy St. Patrick's Day, and thank you for joining our, excuse me, data privacy and public health webinar. We're going to be talking about the impact of COVID-19 on privacy implications, on public health, and hopefully discuss not only some lessons learned, but where we might go from here. Before I introduce our illustrious panelists, I'll say a little bit about Executives for Health Innovation, EHI. We were formerly the eHealth Initiative, but a recent rebrand has made us EHI, EHI with a big E. It's a big change for us. Hopefully some of you have been to webinars of ours in the past, and we're delighted to have you here today. EHI focuses on several different areas of health at a time, and those change depending on where we are in the world, where we are nationally. Right now, our 4 main focus areas are modernizing public health, virtual care, privacy and security, and health equity. I will not read all of these, but here's a representation of some of the executives that make up the EHI membership. And some upcoming webinars that we hope you will all join us on. The interoperability rule is going to be covered next week. We are on Wednesday releasing the second phase of our consumer privacy framework for health data. That's what I've been working on the last 2 years, so a special bias plug for that one. And a couple of other EHR usability and optimization solutions and provider data not being the source of surprises coming up as well. You can register for all of those on our website. This webinar is part of the education series that we've been conducting on public health modernization. So this is the second, I believe, in the series, and we hope that you will keep an eye out for future offerings. The last one that we had was covered what the pandemic exposed and taught us about our public health system, and you can view the recording of that on our website. We will also be posting the recording of this webinar on our website after we finish. Another webinar that's on our website currently is one that I did last week, humorously titled Hipaa for Dummies. We're going to be talking about Hipaa today. So if that's something you'd like to learn more about, you can see that on our website. Certainly does not imply anybody's dumbness, but it is sort of a nuts and bolts on our nation's primary federal privacy law. All right, now to the good stuff. We are going to be talking about data privacy and public health. And I am thrilled today to be joined by three fantastic panelists. We have Chuck Curran, who's at Charles Curran Consulting, Madeline Gitomer from Hogan Lovells. She's a senior associate in the privacy and information management group there. And we have Bill Morella, who is at the Health Share Exchange, one of our nation's health information exchanges. I am Alice Leiter, if you hadn't guessed that already. I'm Vice President and Senior Counsel at the eHealth Initiative, or Executives for Health Innovation. I'm going to turn the slides off so that we can see each other and have a discussion. You are welcome to be part of that discussion by putting your questions in the Q&A box. And just a final housekeeping note that the recording will be on our website, and there will be an email survey follow-up to give you a chance to tell us how fantastic and informative you found this panel. So with that, I'll stop sharing so that you can see everybody. I mentioned briefly who our panelists are, but I want to turn it over to each of them in turn to say a little bit more about their experience with privacy, with public health, and tell us a little bit about the organizations where they work. So Maddie, I will start with you.
Thanks so much, Alice. Really happy to be here, and thank you to you and to eHi for inviting me to talk about these issues. Like Alice said, my name is Madeline Gitomer. I am a senior associate in the privacy and cybersecurity group at Hogan Lovells. Our law firm focuses on lots of different issues, but has very broad and strong regulatory practices. And so I work almost exclusively in the healthcare privacy space. As Alice said, that focuses a lot on Hipaa, but increasingly on lots of other US laws that affect privacy and cybersecurity. In particular, I work with more traditional companies that focus on healthcare, but then also a lot of tech companies, startups, and other larger tech companies, as well as research organizations and academic medical centers that are either getting into or players in the healthcare space, trying to figure out how to either comply with certain privacy laws or make sure that they stay away from certain privacy laws. So, particularly at the onset of the pandemic, a lot of our clients and a lot of organizations in general started having questions about when it's appropriate to share data for public health purposes. So we've helped them navigate that over the past 2 or 3 years. And it, as the webinar title suggests, that has also highlighted some of the choke points, if you will, in the process. And so I'm really excited to be here today to discuss that with everyone on this call.
Thanks so much, Maddie. And I'll go to you next, Chuck.
Hey, thanks, Alice. My name is Chuck Curran. I'm a data policy consultant, and a lot of my work focuses on how privacy and other sorts of data management preferences get presented to users, and how organizations manage these preferences and comply with law. It's great to be back with the eHi, because last year we were talking with Alice and actually with Maddie about digital health passes, and it's an interesting intersection last year where we were thinking about public health data, and their public health data is a source of verification for health credentials showing vaccination. So it's sort of last year sort of previewed and got me a lot deeper into the legal state and federal issues gating access to public health data. So in effect, eHi, we're going to the broader use cases beyond just some of the technologies that were at the forefront of the discussion, the policy discussion last year, not just obviously the digital health passes, but also the exposure notification apps. So we're going into to much bigger topics here when we talk about the totality of COVID-19 and digital and data use and privacy.
Thanks, Chuck. And last but certainly not least, Bill.
Yeah, thanks, Alice. Good afternoon, everybody, and thanks to eHi for inviting us to participate in this. My name is Bill Morella. I'm Vice President of Value-Based Care and Data Analytics at HSX, or Health Share Exchange. So we are a health information exchange serving about 14 million people in the Delaware Valley. So it's the area around Philadelphia, including parts of Pennsylvania, New Jersey, and Delaware. Hopefully everyone knows, I know this is a healthcare audience, so hopefully everybody knows what an HIE is. But for anyone who might not have encountered one of us before, there are about 80 HIEs around the country who are managing data exchange among different people in the healthcare industry, between payers, providers, community organizations, and in these days, even patient-facing apps. We've been involved in our region's response to the COVID-19 pandemic, and we were one of about 23 or 24 HIEs around the country that were given grants from HHS to support our local public health agencies in the pandemic. Much of that work had started before that grant became available. A lot of what we were doing was to try to be good citizens in a moment of crisis, and that grant was to really support that on an ongoing basis. So some of what I'll be covering today will be about what we did during the early days of the COVID pandemic and how that's now being translated into changes in the way we exchange data overall, and some new technologies that we're rolling out.
Thanks, Bill. And that's a fantastic breadth of experience. We have an expert in the law, we have an expert in the policy, and we have an expert on the ground implementation of all of these things that we're going to be talking about. As I said, I'd really like this to be a discussion, and so I will not have any of you give a formal presentation, but I just wanted to start by noting that although COVID-19 is not the only public health crisis that the United States has faced, it's certainly one of the most significant that us and this generation have faced. And there have been a number of public health responses to COVID, contact tracing, COVID testing, vaccination efforts, digital health credentials, as Chuck mentioned, that have raised a number of privacy concerns. But that said, rather than creating these rather than creating privacy issues or privacy risks, what they really have done is exposed weaknesses and risks that already existed in our healthcare system and in our legal system, sort of shining a spotlight on issues that were already there before, but bringing them to national attention and relevance in a way that we previously had not seen. So I wonder if we could just go in turn, and each of you could talk about the ways in which you've experienced this illumination of data privacy issues, risks, panic in some cases that have arisen in the context of COVID. Maddie, maybe I'll start with you.
Yeah, that sounds great. Thanks, Alice. And I thought it might be helpful from a legal perspective to just provide a quick overview of sort of what is permitted under Hipaa, and then for data not under Hipaa, because that has been what has governed some of the sharing, but also contributed to some of the confusion. And so very briefly, I think most folks on this call likely know that Hipaa does permit disclosures of data for public health purposes, but depending on who is sharing the data, with whom they're sharing the data, and what types of data, the different rules, even within Hipaa, apply, right? So when we're talking about public health disclosures to public health agencies, a lot of organizations can share lots of data, right? Protected health information, but with very limited recipients, right? When we're talking about limited data sets or de-identified data, that data may be able to be shared broadly, but or more broadly, but it's much less rich data. And in many cases, what we've seen with our clients is that the recipients are saying this data isn't specific enough or doesn't allow us to link data over time in a way that allows us to address the critical public health needs. And so more data might be needed, which is when we start seeing issues related to concerns about privacy. So, and then of course, there's data that's not subject to Hipaa, right? So for example, when I'm sure everyone has seen on the news or on social media, folks who allege that Hipaa applies when they enter a restaurant and are asked to provide a vaccination record. Of course, it doesn't in that case, but there are other times where it can be really confusing to determine whether Hipaa applies to certain data. And that that is often why folks can come to us, right? So it's not an easy question. But what we see is that, and we'll talk more about this later, between state laws, federal laws, and an evolving landscape, right? For example, I think folks felt grateful that HHS pretty rapidly put out guidance that that clarified, for example, that business associates or service providers could more broadly share PHI for public health purposes than they had been able to previously. But the landscape evolved because HIPAA hasn't been updated in quite some time, and technologies, right, haven't necessarily. Technologies, it's sometimes not clear where they fit in to the current legal landscape. So those are some of the challenges we face, and I think at a very high level, we've been working at our law firm to navigate a lot of those questions, but of course, very, very quickly, because the pandemic has moved rapidly and we've had to keep up. So I'll pause there, but I think there's a lot to dig in. So those are just a few of the issues that we see.
That's really helpful, Maddie. Thanks. And as a second plug for the HIPAA for Dummies webinar that does talk about some of the permitted and prohibited uses and disclosures under HIPAA, if that's something that you'd like to learn more about. Chuck, I'll go to you next, please.
Yeah, I'll just add on to what Maddie was saying. The public health data uses for COVID are just, it's a gigantic set of issues, but it's even a subset of a much larger set of issues of public health use of data and privacy generally. Obviously, the privacy expectations that apply to data gathered in response to a public health emergency for an infectious disease are different. Both the public expectations are different for data that's gathered for ongoing public health work for chronic disease. So right there, you have a dichotomy in sort of the expectation set and the scope of data. As well, there are the question of what kind of data is needed. Is population level data sufficient for the public health objective? It may be, in the context of infectious disease like COVID, it may be sufficient to have case counts to measure, or in the case of chronic disease, if you want to measure the prevalence of pediatric asthma. You can get by with data that doesn't implicate privacy concerns. Even with population level data, if you get into geodata and starting to map it out, there too you start to verge on privacy issues to the extent that it might reveal individual location. But it's clear that there's certainly cases where in public health you need personal information. Most obviously for infectious disease, data is being used potentially for quarantine or isolation for pretty stringent public health measurements. And even in the context of chronic disease, you might have data access for public health purposes. For example, if you were instead of just measuring pediatric asthma, you are actually trying to do affirmative outreach to kids who've been most frequently hospitalized, you'd want to actually get access to personal information to accomplish the public health objective. I know Bill is going to get into this, but certainly with COVID and David Horrocks in the last from the Maryland Health Exchange talked about this in the last EHI webinar. Had some very complex use cases for COVID, where you had integration of data from state vaccination databases with clinical data about people's prior conditions and their demographics, and health information exchanges like Bill's stepping in to integrate this data, where you're basically trying to cut across all the different data silos and to say, all right, we need to figure out who is or isn't vaccinated, and who among those are the most high priority risk based upon chronic disease, demographics, or whatever, and then subsequently tracking them to see outcomes. So you have those use cases. And then you can go on to other public health use cases like syndromic surveillance, which is the process by which data that's entered about people in emergency rooms about what conditions they're suffering from can be monitored even before there's a diagnosis. And that's used, it can be used for infectious disease It can be used for gastrointestinal diseases, for foodborne pathogens. It can be used for bioterrorism. It can be used for mapping outbreaks of vaping injury. So there are both chronic and infectious disease uses for some fairly frontline data monitoring. And I think I would just conclude by saying that for all these different use cases, then you have a tool set of different things that you can use to, de-identification, limited data sets, retention limits that tie the use of data only to the scope of a public emergency, or data use agreements that basically put firm lines down about who can or stopping secondary uses that patients and citizens don't expect, and also just setting some red lines so that that there's public trust in the data use.
Very helpful, and a lot to unpack there as well. Bill, of course, I'll turn to you now. And I also just was noted that one of the things Maddie mentioned was the speed that everybody has needed to employ to respond to COVID. I know that can be challenging from a legal perspective. I also would love to hear how some of the privacy challenges that you deal with have been exacerbated, perhaps, by the rapid need, the need for a more rapid response, perhaps, than usual.
Sure, yeah, happy to cover that. So, if you think back to the early days of the pandemic, we really didn't know how bad it was going to get. We didn't really know entirely what we were dealing with. And frankly, we didn't even have codes in the EMR to be able to track COVID or the results of lab tests. It was really quite chaotic in the beginning. And the public health agencies really had nothing to manage the pandemic with other than lab test results. And those lab test results generally lacked a ton of context that would be needed to make sense of them. So they knew that a test had been done and whether it was positive or negative, but they didn't know much else about that patient. The patient's address might not be there, their race, ethnicity, age, whether they were hospitalized, what their outcome was. None of that information was available with those lab tests. So what the health agencies asked us to do was to provide some context. And we did that in a couple different ways. And so let me cover sort of what data we have been sharing and how the health departments have been using it. So the first thing that we did was enable COVID case finding. So in addition to the lab tests that were being done, originally the lab tests could only be done by state labs. That eventually rolled out to eventually the commercial labs and the health systems. But in the early days, it was just, in our region anyway, it was just the state labs that were doing it. But people were making diagnoses clinically in the health systems, and we were picking those up and sharing those with the health department, and all identifying data. We were also helping them with contact tracing. So once people stood up their ability to do contact tracing at the scale that they did it for COVID, they found that their hit rate was very, very low. They weren't able to find a lot of these people. They were having trouble with non-native English speakers, and people would hang up before they could get a translator on the phone. So we actually shared a jurisdiction-specific roster with the health departments to show them people who were living in their region, race and ethnicity, contact information, and their primary language, so that they could get, for instance, get a translator on the phone ahead of time so they were ready to go when the person answered. The next, eventually everyone's attention turned to vaccine rollout. And, as Chuck described, we were, the state registries were one source of information. We were also seeing people having the vaccine administered by the health systems originally before it rolled out to, the pharmacies are doing the bulk of it now, of course. And what people were asking us for was, we had payers who were attached to us, large health systems who were saying, look, we want to reach out to the people we're responsible for and make sure that they're getting on a vaccine schedule. We want to make sure that we have enough information to prioritize the right people. They even asked us to help them identify people who were homebound who had mobility issues, who may be paralyzed, and would need someone to go to their home to vaccinate them. So, we enabled all that as best we could, although one of the big flaws, and we'll talk a little bit more about this, is the vaccine registries were not really set up to do bulk data exchange. They were set up sort of to manage one patient at a time, for a physician to look up the patient who was in their office at the moment, or to enter data one at a time. They really were not built for what we were asked to do, which was, here's my roster of 1 million patients. Tell me every 3 days what the latest is on their vaccine status. So we enabled that as best we could with the information we had, but we could not get the vaccine registries to do bidirectional data exchange with us, partly because of policy issues, but also technology limitations as well. So just one more point before I turn it over. So the legal basis for what we did in the early days, without the Hipaa waiver of enforcement that Maddie mentioned, it would have taken us much longer to get up and running with those data exchanges. As it was, the waiver of enforcement and the emergency declarations sort of gave us the a legal bubble to operate within, that our members accepted, and we signed an MOU with each of the public health agencies. They were very brief documents compared to what we typically put in place. And then, we gradually, transferred those agreements into much larger agreements, and are now, we've even adapted our population health use case, or I'm sorry, yeah, our public health use case, to enable further data sharing that I'll talk about as we go forward.
Thank you for all your hard work. It sounds amazing. You accomplished a lot under very stressful circumstances. With respect to this enforcement waiver, or that HHS put into place along with the declaration of the public health emergency, I remember that there, and probably still are, two fairly distinct poles of opinion on that. One, that this was necessary, certainly necessary in the sort of crisis period to respond to COVID, largely to enable some of the things that you talked about. Also, just more broad provision of telehealth was really paramount at the time. And then it also scared some people that there was going to be less oversight, less enforcement, more potential for data abuse or misuse, and that just overall it was a weakening of federal privacy that needed to be shored back up immediately. I wonder if any of you can speak to that, or where you see the feds going, if there's some good things that have come out of this, enforcement discretion, or perhaps easing up on some of the enforcement efforts that are good and that we should put into place. Bill, like, it sounds like this enabled all sorts of important work that wouldn't have been done, but that maybe some other parts of it can be tightened back up, so that the privacy, of patient information doesn't get thrown out with the bathwater, so to speak.
Yeah, so I guess, from my perspective, of course, I'm a data sharing evangelist, given my role, but so I generally think that more data sharing is better, but certainly it has to be within the bounds of the law and regulation, and people's expectations for privacy. So when I talk about the use case for public health data, the balance that we struck with our members, because the data that we hold is not ours. It belongs to the patients and the members who are creating it, and we can only do what they let us do with it. So a use case is something that governs, gives us sort of the rules of the road for data sharing. And the agreement that we came to was that for mandatory reportable data, so things that by regulation a provider must report to their local public health agency, we could send identifying data for those cases, because they were entitled to the data anyway. It was a legal requirement, compliance issue. There really wasn't much controversy around that. But once you get beyond the mandatory reportables, which are generally all communicable infectious diseases, and you start talking about things like diabetes, asthma, heart failure, those were areas where we can provide at will de-identified or aggregate data. But if we want to provide identifying data in around those conditions, we have to get our members' permission, and they have an opportunity to opt out before we can act on that.
Yeah, I would just add, I agree completely with with what Bill said, I think another way to think about the enforcement discretion is from a security perspective, right? So it's one thing to have two organizations that already have a lot of, robust security controls in place, sharing data a bit more expansively than they had been given the pandemic or given the public health emergency. But there's also instances in which you have folks who have not been subject to HIPAA or importantly, the HIPAA security rule now transmitting or even maintaining PHI. And I think there can be concerns with the security of that data. And I know we'll talk about it further, but where HIPAA doesn't apply, the security of that data is at risk. And we've seen that, and that I think contributes to, like Chuck said earlier, some trust issues on behalf of patients and users of these apps and tools. And I think one other note I'll make here is that this is, I think, a place where had federal regulation kept up with technology, we may not see these concerns. So, for example, we have a lot of clients who want to share data in a tokenized way, right? Or federated data. But right now, in order to do so in a de-identified way, they need to get all of that data or that process statistician certified, right? And there's only so many statisticians. That analysis takes time, and we don't have that time, right? And of course, under the safe harbor de-identification standard, we're just not really able to link data over time and across organizations. And so one thing that we've thought about, for example, one example I think that is helpful is COVID variant surveillance tracking, right? So when we see new variants, it's really important to think about how, which variants are going to be variants of concern, and then what are the outcomes for patients that have those variants of COVID. The only way we can figure that out is to get lots of folks in the healthcare ecosystem linking their data together. And in many cases, we're not able to do that in an identifiable basis, or if it's de-identified, we're just not able to keep up given the regulatory obstacles that are in place. And so I think those are concerns that some of the enforcement discretion have alleviated, but some remain despite the guidance from HHS.
I think that's really well said. And Maddie, a great segue into what I wanted to ask about next, which is this issue of trust, as you mentioned. There are all sorts of data sharings that are occurring between HIPAA-covered entities and providers. There are also some data sharing that's done by individuals. There was the potential for data sharing or uploading by individuals that would have helped us with our COVID response. Bill, you mentioned the sort of dismal uptake of contact tracing, at least with respect to apps, and in particular, there were some countries where contact tracing was much more successful because of the ways that was implemented. The US had all sorts of contact tracing programs established very quickly, and all sorts of app developers rushed something to market quickly, and very few people felt comfortable downloading them, or even if they downloaded them, using them, because there was this sort of general mistrust of, well, I don't want anybody to know anything about my health condition. I don't know where the data is going. I don't know who's going to see it. And so here's another example of something that COVID shone a spotlight on, just generalized anxiety about individual data and privacy of information. But that existed certainly before COVID. And again, Maddie, as you mentioned, in the absence of comprehensive federal data privacy legislation, we have all sorts of health data that's out there in the world that's just as sensitive as the data that would be covered by HIPAA were in the healthcare system, but is not protected really by anything other than state law. And in some cases, there's some FTC backstops out in the non-healthcare world. So given that we would like individuals to feel more of a commitment to protecting not only their own health, but the health of the public, and feeling like they can be part of a greater public health solution and engage more with the health system, in order for that to take place, we need to find ways of shoring up general trust and privacy in health technology in the healthcare system. And I wonder what role you see patient trust or consumer trust playing in future, hopefully more successful public health responses in the context of the work you each do.
So if I can jump in on the,
Please.
I would distinguish between disclosure and trust building and education, because they're kind of two different things in the public health context. Because current disclosure practices, legal disclosure, primarily HIPAA driven, is that public health is being disclosed as required or permitted by law. And there's not a lot of that's on a piece of paper, or maybe it's on an electronic click through, but it's not really providing much fill-in on what the use cases are and why that's a good thing for both patients and their communities. And then you have the reality that there are important sources of public health information, such as the state vaccine information databases. States like Texas requiring actual consent for use of adult information. So you actually have a consent threshold to get over if you want that data. And then you have a bill, obviously works with a health information exchange. There too, the states are sometimes, depending on the state, you have Florida and New York requiring user consent to have data flow into that. So, particularly where consent is a gating factor to putting this data together, if it's going to be used on a personally identifiable basis, there's a need to not only explain the protections, but to articulate the benefits and to build trust. And there's no national one-size-fits-all solution to this. This policy is on public health data access is determined at the state level. There's no or on a regional level where certain states choose to work together. But you have to think about disclosures that are designed to go beyond just the sort of reporting infectious disease scenario and talking about broader public health objectives and even equity, and trying to think about how you explain those kind of objectives outside of the privacy notice and other forms of public education. And whether you need model notices or templates or some things to ease the burden for trying to give it a go in terms of explaining to the people whose data you're trying to use for their own benefit. I would note there's been some interesting survey work done that it's in the Journal of Medical and Internet Research, showing that people's willingness to share data for public health purposes is actually pretty good. Certainly if contrasted to secondary use for commercial purposes, which is less favored. There's certainly some understanding, some sense of in the public of community and almost kind of the principle of solidarity, that you're helping out others by contributing data. So there's a lot to work with here, but a complex state framework to map it against.
Bill, any thoughts on sort of trust in the HIE context is different depending on how that HIE operates, and it's not always a patient-facing entity. But I wonder if you have thoughts on how to shore up trust, either in the work that you're doing or more broadly.
Yeah, I think everyone is aware that data about them is shared far more frequently now than it used to be, and I think they're all sort of aware that they don't know all the ways in which their data may be shared or all the purposes it may be put to. And not just their healthcare data, but your consumer purchase behavior, your internet browsing history, and things like that. And I think people's concern about whether their data is being exploited for commercial purposes bleeds over into people's concern about their health data being shared. I think if we want to focus on the things that will help us improve or at least maintain people's trust in the kind of data sharing for purposes that we're talking about today, I think the keys there are ensuring that what we're doing with the data is appropriate and desirable, and that as we talk about the things that we did during the COVID pandemic, hopefully people on this call would agree that they were valid things to do with the data. Secondly, you have to afford patients some measure of control. And as Chuck pointed out, some states, when they created HIEs, took the route of saying you can only exchange data on people who have actively opted in to the HIE. New York and Texas are examples of those. And Pennsylvania is in the majority in having gone in a different direction, which was the opt-out method of you can exchange data freely unless a patient opts out. So even in a state like Pennsylvania and Jersey and Delaware, where data is shared pretty freely, we do have the control of patients who, at least if they find out that we even exist, which is a question, they do have the opportunity to opt out. And I can tell you with assurance that all the HIEs honor that. The third key, I think, is, to Maddie's point earlier, making sure that there are appropriate technical controls in place for privacy and security. And, one of the things I did not realize at the beginning of the pandemic is that the public health agencies are exempted from Hipaa. So they are not regulated in the same way that we are. And, but I think the agencies that we work with at least aspire to the same level of technical privacy and security. And not to say that there have not been breaches from public health agencies. There have been some quite public ones, but the same is true for almost every provider and health plan. I mean, every day you read the papers and see the same thing happening at health plans and providers. So I think as long as we can maintain an assurance that we are doing the right things with the data, that people have some measure of control over it, and that we have the right technical controls in place, I think that's how we maintain trust.
Yeah, sounds like there's a need for a massive marketing and communications plan, because very often the things that are being done either aren't understood well by patients, or are misunderstood by patients, or just they don't know at all. So I think you're right that probably more people and agencies are doing the right thing, and unfortunately, one breach headline sets us back a significant amount on this front. Chuck, you mentioned earlier, and I think Maddie, you did as well, and then Bill, just in your remarks right now, it's so clear how what a huge part state law plays in all of this. And those of us who slaved away on 50 state surveys back in our law firm associate days know that every state has its own set of health and health privacy laws, and they are sometimes overlapping and sometimes conflicting. Hipaa is a floor, and these state laws layer on additional protections on top. But it really has created, especially now that Hipaa, as Maddie mentioned, hasn't been updated in a while, and we're still waiting on GDPR-like federal personal data legislation, the states are increasingly active on the privacy front, and it's created this real patchwork on the one hand, gridlock on the other hand of state protection. So, I can imagine, and you all have mentioned that COVID probably exposed some of the roadblocks that these varying state policies have created. I wonder, what do you think can be done about that? How have the state, what are some sort of real world examples of how the states provided some challenges to a coordinated and national COVID response? Are there technological changes that are making some of this data linking or sharing more feasible even across differing state laws? Everyone is always eager to talk about federalism. I know it's such a hot topic. So thoughts just on the state structure of our legal system and how that interacted with COVID.
Yeah, oh, sorry, go ahead, Chuck.
Oh, no, go ahead, Maddie.
Okay, so yeah, I mean, I can just give maybe a quick example of how I see this playing out, and then leave some of the policy discussion to others. But I think it had a huge impact, and I feel a little bit like a broken record, but for organizations that I have worked with or studied, I think the biggest effect during the pandemic, where all healthcare organizations were strapped for both time and resources, that was the cost, right? I think I recall times when I was working with clients to figure out whether Hipaa applied, whether a state medical privacy law applied, whether a state consumer privacy law applied, and then condition-specific laws like a genetic information law applied. And that's in one state, right? And so when you're spending time looking at a data set, and that data set may have, several sources of data, and it takes several teams of people, several working sessions to determine what laws apply to that data. That slows down responses to a public health crisis. And I think in particular, certain laws require, not just notice, but consent, and rightfully so in some cases. But when those laws don't have specific carve-outs for public health purposes in particular, that really slows things down. And so I think there are sometimes technologies that can help with this, but frankly, a lot of state laws don't take that into account. And so I think that's why we've seen some advocacy groups saying, look at privacy protective technologies and allow safe harbors or carve-outs in state law for disclosures that implement such activities. I think that's something that could be really helpful, but I think time and resources are really the cost of having so many state laws across so many states, and then federal laws as well that could apply to just one small data set.
Just on the 50 state point, after the anthrax and 9/11 and the anthrax attacks, there was a sort of model state public health campaign to try to normalize just the frameworks. And one can imagine sort of attempts to try to, recognizing that there will be difference of state views on, it's pretty apparent there are some radically different views across the states on these issues, but at least the templates for data movement or just the concepts used to describe consent so that they're normalized across, in a public health context, across the states. There's certainly, if you think about federal policy right now with for example, the Pandemic Prevention Act, the focus is elsewhere. It's not on adopting a national law that governs public health data use. It's more on strengthening the federal authority to request certain kinds of data from the states directly to basically ensure that there aren't gaps in reporting where if a state fails to gather the necessary data for the federal response that either the CDC or the HHS can compel in a way that they didn't. But I don't think there is a silver bullet of a national, there's certainly no GDPR-like general data construct that's going to be slotted in to solve the public health, some of the public health problems. And, even with GDPR, there's certainly some complexities around exceptions to, legitimate interests uses of public health and how those again are determined and implemented in particular jurisdictions according to local law. So you don't really get around the issue of localism and regional implementation, even when you do have baseline privacy requirements. So.
Go ahead, Bill. Sorry, I didn't mean to cut you off.
Yeah, so I guess, another sort of lesson for me during the pandemic was that the reason that the public health responses are so fractured in different jurisdictions is actually because of the Constitution. So the 10th Amendment actually is the reason why the public health response is situated squarely at the state level. And in a very divided country where half the population wants a very activist federal government and the other half is mistrustful of it, that's not going to change in my lifetime, I don't think. So by definition, any pandemic response is going to differ based on local differences in leadership, politics, and what's going on local condition wise. So I guess from my perspective, the things that would put us in a better position in the next pandemic would be things, and these are things that can change, would be things like putting proactive governance policies in place so that the next pandemic that rolls around, we already have the legal basis for sharing the kind of data that public health agencies will need, including identifying data. And frankly, that data would be shared bidirectionally. So one of the political issues we hit on was that some people felt like the public health agencies couldn't share the vaccine registry data with an HIE. If they had, we would have been able to push it into people's EHRs so that it would have been right there in clinicians' workflow, but they felt like they didn't have the legal basis to do that. The second thing is the vaccine registries. Many of these were homegrown systems. Many of them are 20 years old or more. They desperately need to be updated, and I know CDC is working on a funding program to do that, and to bring those systems up to speed now. And what they need to be capable of is, as I described, that bulk data transfer and making the exchange of data computer processable, as opposed to relying on people to go into a system, to a website, and look things up. And then thirdly, there is a new technology called electronic case reporting, or ECR, that is rolling out around the country in pockets. And those of us who are funded by HHS to do the COVID response, a lot of us are leading this. We're trying to put a system in place that will live within the EHRs at the health systems and actively screen for people who meet communicable disease criteria, and proactively report that out from the EHR to all the public health agencies that have the rights to that data based on where the care is being delivered or where the patient lives. So that technology is going to alleviate a lot of manual work that is done today, and result in much better data for public health agencies into the future. I mean, that is the next evolution of disease surveillance that's being put in place now. So all those things will put us in a better position, should something like this happen again.
Yeah, God forbid that happens again, but that is a nice little bit of optimism that there are some things that we've learned that have come out of this, that have been put in place, lessons learned, and hopefully things that are continuing to be worked on and improved, so that whenever the next wave or next variant comes or next disease comes, we'll be better situated. And that's really where I wanted to end. Part of this webinar's title is, where do we go from here? So Bill, you just teed that up really nicely. And we talked a little bit about federal privacy legislation, maybe helping some of this at some point. Maddie or Chuck, are there other where do we go from here type thoughts that you have, or sort of similar to Bill, what you think, had it been in place, would have helped our COVID response go better, or what we have put into place over the past few years that will make our future public health responses more successful?
Sure. I think I agree with Bill, and then I also think there are a few other things underway that are helpful right now. So I think obviously interoperability is a big thing here, and I know EHI is involved in those conversations, but the interoperability rule is fairly new, and so I think we'll see how that plays out and how that will allow quicker transfer of data. And then whenever we talk about interoperability, we talk about apps and tools that are not subject to Hipaa. And so I think continuing to see what protections are in place. I know the FTC is really thinking about that. I think the FTC has recently come out with some pretty strong statements on what's required in terms of privacy and security outside of Hipaa. And so I think that will be really important, in addition to what Bill said, to because I do think public buy-in is important, and so getting people on board with that is going to be critical. And the way to do that, in part, is by folks feeling like the places that they're putting and accessing their data are safe.
I would just layer on to what Maddie's saying. I mean, a lot you've heard throughout this discussion, this sort of barrier line between plausibly de-identified or data and personal data. And in the public health context, as well as in the clinical context, that's really where the battles are really fought. And certainly if data is going to move more freely, and it does fall over on the side of individually identifiable information rather than plausibly de-identified for that particular use, I think we're looking forward to a future in which sort of health data rights management is going to become a much more as collection and consent or permission or opt out or whatever is proffered to the in connection with the when data is first gathered. You have this concept that it's going to be very complicated, but necessary to essentially start to keep track of the permissions that are associated with data, such that it can be flowed through the system. You see some of this previewed, I think, in the TEFCA framework in terms for national interoperability. Is there's an assumption that whatever is brought into the network will be adequately permissioned, right? That it will not be moved through the TEFCA national framework unless it's authorized. And so, what you have to think about the mechanisms that allow what the patient wants to travel with the data to, for audit purposes, for trust purposes, that you're able to live up to whatever set of representation starts in the beginning, or change your mind, alter your preferences. So that's the longer term future, but obviously a real implementation challenge where you want to have this underlying data interoperability, but you want to make the data contributor a part of the discussion.
So interesting. Thank you. We are almost out of time. I did want to touch on a couple of comments and questions that we got in the Q&A box. First, I will, on the record, correct the New York State approach to consent. I'm being told that there's consent necessary for access, but not to aggregate data, and many exceptions, including for public health reporting. So my apologies if we said anything other than that. And then here's a question maybe best answered by Bill about the difference between sharing healthcare data through an HIE for purposes of providing healthcare services or for billing purposes, versus sharing protected health information in order, for example, to attend a particular venue for a game or a concert or eat in a restaurant that is not a healthcare purpose. Are there varying purposes of this health information exchange that you've experienced, and any different sort of policies that are in place depending on the purpose for which the information is being shared?
Yeah, so I guess I'll go back to what I said earlier about our use cases. So every member who joins HSX signs our participation agreement, and everyone is essentially signing the same agreement. And that agreement basically stipulates that for purposes of treatment and care coordination, as defined in Hipaa, the data flows freely. No one can object to that. When you go beyond that, it gets into an area that we refer to as secondary uses of the data. And all of those uses of the data require a use case in which the covered entities that are participating in the HIE agree to participate in that use case, or they opt out of that use case. So even for something like a population health study that someone wants to know what's the average A1C value among diabetics in our region, if we want to do something like that, we have to go to our members and describe what we want to do, give them an opportunity to opt out of that use case, and then we have to exclude their data, even if it's just purely aggregated data. So when you start talking about businesses requiring proof of vaccination for to get into a venue or something like that, that's not a healthcare use case. I think if it looked like those apps were going to take off in this country, which politically I don't know that they were totally tenable here, but we would have found a way to exchange data for that purpose. The best way to do it would be patient-mediated use of the data. So in other words, if a patient wants to get their vaccine record from us so that they can present it on their phone to whoever, we probably would have enabled that. But it's sort of didn't pass the market test, I guess.
Yeah, that's a great answer. And thank you so much for that question. I obviously could talk to the three of you for hours and hours, but we're right about at 2 o'clock. So I will close there. I will thank all of you for attending and remind you that the recording of this webinar and our intro slides will be up on our webinar, up on our website, where we also have links to recordings of our previous webinars, both on this public health modernization topic and others. This has been terrific. Bill, Chuck, Maddie, thank you so much for joining us. Thank you all for attending, and we will see you all at our next webinar. Thanks so much.
Great. Thank you. Thanks, Alice.